Hello everyone, I'm Shivshankar Challa, an orthopedic registrar working at Western Hospital, and I'm going to talk about ochronosis, a very rare but a very interesting metabolic bone disorder in the short presentation today. Coming to the learning objectives of the presentation today, at the end of this talk, we should be able to understand the pathophysiology and the epidemiology of this metabolic bone disorder, along with its clinical presentation and the symptoms with which the patient usually presents, and the investigations which are useful in diagnosing ochronosis, along with the current evidence and evidence-based practice, which is useful in the management of this rare bone disorder. Keeping the learning objectives in mind, I would start off with a case scenario with a 30-year-old male patient who presented in my clinic and has presented with a pain and swelling in his knee joint with no past medical history, but for chronic knee pain and back pain, which he has been suffering since a long time. On examination of his knee joint, he has had limited range of motion in both his spine and knee, with dark pigmentation observed on general examination over his conjunctiva, the nasal bridge, and also the anterior aspect of his thorax and palms. On further questioning, the patient explains that his urine was observed to turn black on long standing in his toilet. Urine analysis from this patient has confirmed homogentisic acid, and X-rays have confirmed arthritic changes, with X-rays of the lumbosacral spine confirming calcification of the disc and narrowing of the disc spaces. The reason this slide is a conclusion of the presentation is because a typical patient who presents with ochronosis is usually an early adulthood patient, and as in this case, who is a 30-year-old patient with a male predominance, and also the patients usually present with arthritic symptoms and pigmentation of the connective tissues in the body. The diagnosis usually is through urine analysis and detection of homogentisic acid, and X-rays are usually suggestive of osteoarthritic changes rather than ochronotic per se specific changes. Coming to the introduction of the disorder itself, it was a term which was coined by Sir Archibald Gerard in 1902, and it is derived from the term ochre, which refers to a collection of earth pigments which consisted of colors which ranged from yellowish brown to bluish black pigments. And in the case of this disorder, it was the bluish black pigments which are accumulating in the connective tissues of the patients. It is of two types, one being the exogenous and the second being the endogenous type of ochronosis. And the other names which are synonymous with this disorder include the black bone and the black urine disease. Coming to the first type, which is exogenous ochronosis, it is a cutaneous disorder which presents as dermatitis and is characterized by bluish-black hyperpigmentation on the skin due to either topical or oral administration of quinine derivatives, especially hydroxychloroquine and other forms of antimalarials. Since the center point of the talk is going to be the endogenous type, we will not be dealing with exogenous ochronosis in the talk today. Coming to the endogenous ochronosis, it is an autosomal recessive disorder, which means that both the parents should be carrying the recessive gene in order for the gene to be carried or the disease to be carried to the progeny itself. And it is basically caused due to an error in the catabolic pathway of the essential amino acid phenylalanine and another amino acid, which is tyrosine. It consists of a triad which involves homogentisic aciduria, and due to the blackish discoloration of homogentisic acid on long-standing, this is also termed as alkaptonuria. The second symptom with which the patient presents is usually cutaneous hyperpigmentation, and because of the bluish-black discoloration of the connective tissues, it is also termed ochronosis. The third, but not the least, severe symptom is an arthropathy involving the large joints of the body. This is a pictorial depiction of the triad of endogenous ochronosis, with the patient usually having bluish-black hyperpigmentation of the connective tissue involving the skin, the bone, the cartilage, as well as the ears in the body. And the second picture, which usually is an arthritis of the large joints of the body with bluish-black pigmentation seen in the cartilage. And the third symptom being alkaptonuria or bluish-black discoloration of the urine of the patient on long standing. Coming to the pathophysiology of the disorder itself, it is an error in the catabolism of phenylalanine and tyrosine, which are amino acids involved in the production of fumaric acid and acetoacetic acid, which are a part of the Krebs or the PCA cycle useful in the production of ATP in the human body. The disorder itself is due to a deficiency of homogentisate 1,2-dioxygenase, which is an enzyme involved in the degradation of homogentisic acid, and this in turn accumulates in the connective tissue of the body, leading to bluish-black discoloration on polymerization of homogentisic acid. The term alkaptonuria is derived from the fact that the urine of these patients, usually on long standing, turns bluish-black in color, and the other enzymes of note in this particular catabolic cycle are phenylalanine hydroxylase, which is involved in phenylketonuria, leading to an accumulation of phenylalanine within the body. And these patients usually present with mental and growth retardation, along with musty odor, and usually present in early childhood. The other enzyme of notice is tyrosine aminotransferase, which leads to an accumulation of tyrosine when there is a deficiency of this particular enzyme. The severe form of tyrosinemia, which is tyrosinemia type 1, involves growth and mental retardation, with the patients usually not making it through beyond 10 years of age due to accumulation of tyrosine within their body. Tyrosinemia type 1 has also been involved and is known to be one of the causes in the etiology of rickets, with the patients usually presenting with softening and weakening of their bones. Fumarate acetic acid hydrolase is another enzyme which is usually involved in tyrosinemia type 2 and type 3, which are the less severe forms of tyrosinemia. The other enzyme which is of note is 4-hydroxy acid dioxygenase, which is an enzyme which is inhibited by nitisinone, which is a drug which has been postulated to be used in the medical management of ochronosis. And we will be dealing with this in the later part of the lecture. As previously mentioned, the disorders associated with the catabolic pathway of phenylalanine and tyrosine catabolism are phenylketonuria, tyrosinemia type 1, 2, and 3, with the type 1 being the most severe form, and alkaptonuria, which is a part of endogenous ochronosis. Coming to the etiology of ochronosis, it is due to the HGO gene missense mutations on chromosome 3, which leads to the HGO aberrations, leading to the deposition of homogentisic acid in the connective tissues, especially of the bones, the cartilage, eyes, and the urine of the patients. In a study done by Ladu BN in 2001, it has been postulated that HGA levels can reach up to 100-fold the normal levels in patients presenting with ochronosis. To summarize the etiopathogenesis, ochronosis is an autosomal recessive disorder of phenylalanine and tyrosine catabolic metabolism, and it is due to the deficiency of homogentisate 1,2-dioxygenase or homogentisic acid oxidase enzyme, which leads to the accumulation of homogentisic acid within the connective tissues, and the polymerization of which leads to bluish-black discoloration of the connective tissues within the body. This is mapped to the HGO gene missense mutations, leading to homogentisic acid oxidase aberrations, and the result of this is the deposition, as previously mentioned. Coming to the pathology involved in ochronotic arthropathy, it can be divided into the cause for the ochronotic arthropathy, the reason behind the cartilage destruction, and the end result or the reason for which the patient actually presents to the clinic. The cause for the pathology is due to accumulation of HGA in the cartilage, and interleukin 6 has been involved in this particular pathology. And the reason for the cartilage to be destroyed is due to fragmentation and degeneration, and eventually leading to pigment polymerization, which is nothing but the HGA, which is polymerized into a bluish black pigment within the cartilage, making the joints appear bluish black in color eventually. The end result is this fragmentation of the cartilage leads to irreversible destruction of the cartilage with brittleness and arthritic changes within the joints, and the patient usually presents with osteoarthritic symptoms in their early adulthood, which is usually in the third decade of their lives. Coming to the most common joints which are involved, the knee joint is the most commonly involved joint, with the hips, shoulders, SI joints, and the lumbosacral disc spaces being the next common sites in the order of decreasing frequency. The fact that this disorder is quite a rare one can be reflected from the epidemiology of this particular disorder, and with its prevalence range being between 1 is to 125,000 to 1 is to 10 million per live births worldwide, with a higher incidence rate being observed among the Europeans, especially the Slovakians, and also the Dominican Republicans. Coming to the clinical features and the clinical presentations of these patients, it can be broadly divided based on the age group of the patients and the age at which they usually present in the clinic. The first age group is the childhood or at birth, when the patients themselves are usually asymptomatic and the mothers are the usual complainants, with the main complaint being the urine of their babies turning black on long standing, or when the nappies are left overnight, the nappy is turning black. This usually is a scary sight, and this is the usual first presentation if the child is brought in early with ochronosis, though this is a rare presentation. The second age group, which is the most common age group at which ochronosis is usually diagnosed, is the early adulthood, which includes the second half of the third decade, and these patients usually involve or present with a brownish black pigmentation of their sclera, which is known as Osler's sign, and it is clearly seen on their eyes, with blue pigmentation also seen in their ear cartilage as well as the ear lobes, as well as the anterior aspect of their nasal bridge, along with anterior thorax, and other common site being the anterior aspect of their palms. Osler's sign is also useful in the clinical diagnosis of this disorder. The other common, or in fact, the most common presentation of this category patient is the involvement of the large joints as well as the lower spine in the form of chronic pain issues. The radiological findings in these patients are usually osteoarthritic symptoms or signs radiologically, and as far as the spine is concerned, there is calcification of the intervertebral disc along with disc space narrowing, which is usually seen. The other unusual presentation of these patients could include axillary and inguinal areas dark pigmentation, and sometimes soiling of their clothes due to dark pigmentation on long-standing perspiration. The last age group is usually the middle age, or say in the fifth or the sixth decade, where the usual complaint of the patient is ochronotic arthritis with limitation of the motion and ankylosis. And this resembles osteoarthritis and rheumatoid arthritis as far as the presentation is concerned. As far as the non-arthropathic symptoms are concerned, these are usually the symptoms with which patients of the middle age or the late adulthood usually present with. These involve kidney, prostate, and bladder stones, which are usually pigmented in bluish black colors. And the other connective tissues like heart valves and the skin are also involved with a bluish black pigmentation. 40 to 60% of these patients are said to have hearing defects along with heart valvular defects. A study done in 1999 by Hamdi et al. Has postulated that the late presentation of patients with ochronosis with an asymptomatic childhood is attributable to the fact that the renal clearance decreases as the age progresses. Coming to the evidence regarding the clinical presentation and the clinical symptoms with which the patients usually present, Von Futkal et al. In 2002 had studied the natural history of this disorder and had evaluated 58 patients of the age range between 4 to 80 years. They've observed that arthropathy is the most common presentation of these patients, and half of these patients have had a form of a replacement by the mean age of 55 years of one or the other large joints in their body. 27% of these patients had renal stones by the age of 64 years, and the mean age for cardiac valve involvement and coronary artery calcification was around 54 and 59 years respectively. There was another study which postulated that aortic valve is common involvement in patients over the age of 40 years when the patient is diagnosed of ochronosis. Coming to the investigations which are of particular use in diagnosing ochronosis, more often than not, it is a retrospective diagnosis with the patient usually presenting with arthritic symptoms, and it's only during the intraoperative period that the bluish black pigmentation of the joints alarms the orthopedic surgeon about ochronosis. Later on in the postoperative period, when the urine is sampled for HGA, it is only then that ochronosis can be given as a primary diagnosis for the arthritic symptoms of the patient. The natural history study, which was done by Von Futkal in 2002, had postulated that the mean age for the diagnosis of patient with ochronosis is around 1 year in 21% of the patients, which is 12 patients out of the 58 they've conducted the study on, while the majority, which is 79% of the patients, usually presented at 29 years of age, which again confirms the fact that the presentation of the patient is usually in the early adulthood rather than early childhood or after birth. The diagnosis can be confirmed by urine analysis and sending the urine and subjecting it for alkalinization or addition of ferric chloride, which turns the urine black. The other method, which is of particular use and of high sensitivity, is gas chromatography of urine, which leads to the detection of HGA in urine. X-rays and CT scans are useful for patients who present with arthritic symptoms, and the changes are usually osteoarthritic findings in the large joints, while the lower spine usually shows pseudoblock vertebrae, which is nothing but calcified discs in the spine, and this should not be confused with the bamboo spine appearance seen in ankylosing spondylitis. And even in ankylosing spondylitis, the patient's age group coincides with that of ochronosis. CT scan of the joints is useful only for preoperative planning, but not of a diagnostic value when it comes to ochronosis. MRI of the spine is invaluable in understanding the foraminal stenosis or the lower back pathology which may be underlying this disorder due to long-standing calcification and intervertebral space narrowing. As far as early diagnosis or prenatal diagnosis is concerned, amniocentesis and chorionic villi sampling have been proven useful, and DNA analysis for the mutation of the gene on chromosome 3 has also proven to be beneficial. The point to remember is to understand that the tyrosine levels of these patients is usually of the normal level. As far as the management of these patients is concerned, it would be ideal if a multidisciplinary team actually handles these patients in the form of a biochemical analyst, an orthopedic surgeon, a neuro or a spinal surgeon, and a cardiologist who are all involved in the management of this patient. And this would enable an wholesome treatment for this tricky disorder. Coming to the medical management of Ochronosis, it is usually involving symptomatic treatment, as most of the patients usually present with arthritic symptoms as the main complaint, and NSAIDs generally form the first line of drug management for pain in ochronotic arthropathy. Physiotherapy and occupational therapy advice on offloading the joint would be beneficial, and other forms like weight loss would go a long way in the treatment of these patients. The medical management in the form of pharmacological drugs include nitisinone, which is a 4-hydroxyphenylpyruvic acid dioxygenase inhibitor, which decreases the level of homogenesic acid production but does not compensate for the lack of homogenesic oxidase enzyme itself, and hence there is a slight accumulation of HGAC even with the use of nitisinone. It is dosed at 2 milligrams per day, but there are no benefits once the arthritic symptoms have begun in the patient. Ascorbic acid, popularly known as vitamin C, dosed at 1 gram per day, is observed to reduce the polymerization of HGA in the connective tissues, but the efficacy has not been proven, but observed to reduce the progression of arthritis once the patient presents in the clinic. As far as the surgical management of ochronotic arthropathy is concerned, pain is the major symptom which needs to direct the surgeon towards acute orthopedic intervention. Pain which actually does not allow the patient to perform day-to-day activities and disturbs him from sleep is the only indication which is similar to osteoarthritic joints, which leads to the decision of actually replacing the large joints in the body affected by ochronosis. So any hip, shoulder, or knee pain which is debilitating for the patient needs to be treated with arthroplasty, and lumbosacral spine with lower lumbar pain or lower back issues can be treated with decompression or a fusion of the adjacent spinal vertebrae with or without discectomy, as in most of the cases, the discs are usually calcified. As far as the evidence-based approach for the surgical management of ochronotic arthropathy is concerned, there was always a doubt within the orthopedic surgeon's mind regarding the quality of the bone and also the bone osseointegration as well as the bony ingrowth is the implant needs for a good arthroplasty surgery. Keeping these doubts in mind, Rajshekharan et al. In 2020 had published the results of 16 patients going retrospectively for the past 10 years. And the 16 patients had undergone 27 joint replacements, and the functional outcomes and the radiological outcomes of these patients were assessed for. The functional outcomes were assessed using the Knee Society score and the Harris Hip score for the knee and hip replacements, while the Knee Society radiological outcome score and the Hip Society outcome score were used for radiological assessment. The study concluded that the quality of the bone is good in any patient presenting with ochronotic arthropathy, while the cartilage quality is quite brittle as expected in any arthritic joint. Uncemented prosthesis had yielded good bony ingrowth, which can help in directing us to understand that any joint arthroplasty would most probably be successful in a patient with ochronotic arthropathy. There was a functional improvement as far as the knee score and the hip score are concerned, with almost a threefold increase in the patient satisfaction as far as the functional outcome was concerned. These results were quite encouraging and could pave a good direction for future orthopedic surgeries or planning of arthroplasty surgeries is concerned for any patient with ochronosis. There were quite a few other studies which actually studied the functional outcomes of a patient undergoing total joint arthroplasty after being diagnosed of ochronosis as the primary diagnosis. A study done by Harun et al., Hamdi et al., and Kefeli et al. In the early 2000s had actually postulated that all patients have had good functional outcomes and were comparable to patients who have had total joint arthroplasty after osteoarthritis, even though the primary diagnosis was ochronosis. There was another study in 2013 by Osmanevra, who postulated that bone osseointegration and bone healing were comparable to the patients with a preoperative diagnosis of ROA, even though the diagnosis of the patient was ochronosis. The only weakness of all these above studies was based on the fact that they're all retrospective in nature, which could restrict the outcome assessments, as prospective studies would be the ideal way to assess these outcomes. The second weakness of these studies is based on the fact that there are multiple joints which might be involved in ochronosis, which could lead to a false recording of functional outcome measurements. Other than this, the fact that bone osseointegration and bone healing capacity of the patient is not compromised in ochronosis is encouraging for any orthopedic surgeon to take a decision of making sure that the patient is actually given a pain-free and a stable joint in the form of total joint arthroplasty. I would like to end my presentation by using this slide, which wonderfully concludes whatever I've spoken for the last few minutes, and this being about alkaptonuria or endogenous ochronosis. The first point being alkaptonuria is a rare inherited autosomal recessive disorder in the catabolic pathway of phenylalanine and tyrosine due to the deficiency of HGA. It is also known as a black urine disease or a black bone disease, which is due to the polymerization of HGA within the connective tissues of the body. It's quite a rare disorder with affection or prevalence ranging up to 1 in 250,000 people on an average. The risk factor is a positive family history, as it is an autosomal recessive disorder. And as previously mentioned, it is characterized by abnormal phenylalanine and tyrosine catabolism and is associated with heart hearing loss or defects in heart in 40 to 60% of the patients. Most of these patients are asymptomatic during childhood, but darkening of urine upon exposure is the usual complaint during childhood. And it can cause the pigmentation of cartilage of the ear as well as the cornea and the sclera, with the discoloration of the sclera being a pathognomonic clinical sign useful in the diagnosis of ochronosis and is also known as Osler's sign. It is diagnosed using lab tests in the form of urine analysis and in the prenatal screening using chorionic villi sampling or amniocentesis. And the treatment is usually by ascorbic acid supplementation and dietary restriction of phenylalanine and tyrosine. And this is something which I forgot to mention in the medical management of these patients. And complications include damage to cartilage, heart valves, bone fractures, and kidney stones, possibly due to accumulation of phenylalanine and HGA within the connective tissues of the body. With that, I would like to thank Orthopedic Principles and Dr. Gopalan for giving me this opportunity to talk about this rare but interesting metabolic disorder. Thank you.